Episodic headache. Letter of referral. Dear Dr. Mrs. Lucy Carter, aged 29 years. I would be grateful for your opinion regarding this woman who suffers frequent severe headaches. She is a teacher with no significant past medical history, but has had to take an unacceptable amount of time off work because of the pains since going back after maternity leave 4 months ago. I have prescribed her regular codeine phosphate, which she finds is of some benefit. Examination is normal, including BP. Yours sincerely. Introduction. The diagnosis of an episodic headache, as with facial pain, can virtually always be made on the history alone. It is certainly worth taking time over this. The commonest cause of an incorrect diagnosis is an incorrect history. It is important to note that the severity of pain does not indicate whether a headache is life-threatening or not. Your approach to the patient presenting with headache should be to establish the following. Are the headaches benign? If so, what is their cause? In this patient there is a worry that the headaches are related to raised intracranial pressure secondary to a space-occupying lesion, hydrocephalus, or idiopathic raised intracranial hypertension, or that they are caused by a systemic condition. However, it is much more likely that her headaches are benign. It is important to make the correct diagnosis in benign headaches to have the best chance of treating them effectively. History of the presenting problem. It is useful to establish the following. How long has the patient had these headaches? Long-standing headaches, present for over 1 year, are almost always benign, so establish when the headaches truly began and not just when they got worse. In this case, did the headaches start during her pregnancy or after delivery? How often do they occur and for how long? Determine whether she is describing episodic discrete headaches or exacerbations with a constant background, which may also be described as recurrent. Ask specifically about the period between headaches. Where does she get the pain? Is it bilateral, strictly unilateral, alternating unilateral, frontal, temporal, or occipital? The use of a finger or hand to indicate the position will give some clue as to the quality of the pain. What is the pain like? Is it throbbing, migraine, a deep, boring, intense unilateral pain, cluster headache, or band-like tightness and pressure around the head, tension-type headache? The pain of a headache caused by raised intracranial pressure is nonspecific. What does she do with herself during an attack? Most patients with severe headache prefer to remain still, but agitation during an attack is characteristic of cluster headache. Are there any precipitating or aggravating factors? Light, noise, movement, and stress aggravate most headaches and so are not helpful in differentiating one type of headache from another. Exacerbation by coughing, sneezing, or straining is also relatively nonspecific. Alcohol can precipitate migraine and cluster headache during a bout, but may alleviate tension-type headaches. Are there any associated features? Classical migraine may be associated with visual phenomena such as seeing dazzling zigzag lines, fortification spectra. Many patients who experience this feel intensely nauseated. Additional features such as weakness, paresthesia, aphasia, diplopia, and visual loss are often worrying but can all happen as part of migraine aura. Establish how closely these symptoms are associated with the headache. Any residual deficit should be taken seriously and investigated further. This young woman could not have giant cell arteritis, but the diagnosis should be considered in anyone over the age of 60 years with severe headache, visual symptoms, jaw claudication, proximal muscle pain and constitutional symptoms would all support this diagnosis. What medication is she on now? Either it is not working and needs to be changed, or it is contributing significantly to the headache and so should be stopped. The codeine that has been prescribed is unlikely to be helping her and may be precipitating the headaches. NB. Warning symptoms or signs in the patient with headache. Headaches of subacute onset with steady progression over days or weeks. A recent change in pattern or character of an established headache. Association with fever or other systemic features. Association with focal neurological signs, papilloedema, personality change, or seizures could indicate a space-occupying lesion as the underlying cause. New onset of headache in people older than 50 years. Other relevant history. Ask about the following. A previous history of depression, anxiety, or neck trauma will be relevant if considering tension-type headache. Current or previous use of tetracyclines, corticosteroids, or vitamin A derivatives may be associated with idiopathic intracranial hypertension. Recent weight gain or pregnancy in a woman of childbearing age, such as in this case, can precipitate idiopathic intracranial hypertension. Previous head injury, subarachnoid hemorrhage, or meningitis may predispose to communicating hydrocephalus. Plan for investigation and management. You should begin by explaining that under normal circumstances you need to confirm that her neurological examination is normal. Investigations. Consider the following. Blood tests, erythrocyte sedimentation rate and C-reactive protein are important tests to carry out if giant cell arteritis is suspected, otherwise blood tests are rarely helpful unless systemic disease is suspected. Brain imaging. It is often difficult to decide whether a patient with headache needs a brain scan. The yield will be very low and not infrequently an incidental finding will cause some difficulty. There is also increasing awareness of the exposure to radiation associated with CT scanning, equivalent to approximately 100 to 150 CXRs. However, if a clear diagnosis cannot be made and there are uncertainties as to whether the headache is benign, then it may be appropriate to perform a scan to exclude a space-occupying lesion or hydrocephalus. Imaging may demonstrate slit-like ventricles in a patient with idiopathic intracranial hypertension, but may also be completely normal. Lumbar puncture. A diagnosis of idiopathic intracranial hypertension is confirmed by measuring an elevated opening pressure on lumbar puncture, greater than 25 cm H2O, after normal brain imaging has been obtained. Management. Management depends on the particular cause. For migraine, cluster headache, and tension-type headache with exacerbations. For idiopathic intracranial hypertension. 1. Provide the patient with dietary advice to lose weight. 2. Repeat lumbar punctures. 3. Give the patient acetazolamide 750 to 1000 mg daily. 4. Be aware that deterioration in vision is likely to need optic nerve sheath fenestration. Further discussion. In a young woman of childbearing age who has recently been pregnant or gained weight, idiopathic intracranial hypertension must be considered. Patients characteristically present with a gradual onset headache associated with features of raised intracranial pressure. They may also complain of visual obscurations, transient bilateral visual loss occurring with changes in posture, and occasionally tinnitus. The headache itself has no specific features. NB. Idiopathic intracranial hypertension is no longer called benign because of the danger of progressive visual loss associated with papilloedema. Sight must be monitored by regular formal visual field testing and intraocular pressure measurement, not simply by testing of acuity.